Assalamu alaikum. Good afternoon, everyone. My name is Omar Musa. I'm a doctor from Amsterdam. Been focusing on my PhD for the last 2 years in Boston, MGH, Harvard, where today I'm moderating the session called Designing the Futures of the Hospital, and where we are, of course, trying to focus with this tremendous amount of people that have been helping the patients at the core over the last couple of years. Today we get a chance to ask for their insights, experiences, expertise, while at the same time I guide us through some little refreshment as in visuals. I know we have been hearing a lot of very micro-focused presentations before. We're gonna take it a little bit more to our own world, what we see, what we do for us, surroundings, not only for the patients, but also as human beings. So, to not get too distracted. These are some disclosures which are irrelevant for this presentation, and then I want to introduce our wonderful panelists by one. We have Adriana Spetzak, please forgive me for my pronunciation, who has been a group director for people experience at Apex Health Qatar, with her background in the United States at Stanford and Cornell. She bridges a beautiful gap where she brought this all to the Gulf region here and has been renowned for multiple awards throughout her background. Then we have Dr. Pietro Garbelli, where Dr. Pietro Garbelli also is a clinical director in acute medicine, has been practicing in the UK for a tremendous amount of years, has been a writer with successful books, and of course has been renowned in the literature over the past couple of years. Today, he wanted also to talk about his experiences at the Havelhohe, again, sorry for the pronunciation, where he had some experience with the anthroposophic hospital model, and he wants to talk about the holistic care model in which we are a little bit lost with our reductionist kind of perspective as doctors. Then, taking it over to Dr. Nada Fida. Nada Fida is a director in emotional intelligence coaching with Bright Future Consultancies, patient experience advisor for over 20 years, empowering healthcare professionals and organizations globally and especially here. Then we have Dr. Alexandra Filipovic, where Dr. Alexandra Filipovic is the CMO of Gallup Oncology, Pure Tech Health, and has bridged from his 20 years of oncology this over as a holistic model to a whole clinic. With the master in coach somatic intelligence, he knows all about the into the weeds perspectives, but also about the multidisciplinary care model, which is broadly used in oncology. Also, then Dr. Sushil Sharma, director of the health oncologies with the device manufacturing over the years, and together also with the other panelists focusing on the holistic healthcare for the patient instead of the productivity numbers. Last but not least, Adarsha K, founder and CEO of Sui Clinic Digital Technologies, with also focus for the remote healthcare, not only in the hospital, but abroad when people go at home. So, with all this, without further ado, what I have been doing is trying to see what kind of systems we need to best try to heal and have the patients that having limb salvage surgery, meaning surgery in the arms and the legs for whatever reason, different etiologies, how we can not best give them surgery only, but also beyond that, treat them in a multi-approach model, mentally, but also psychosocially, and also, of course, the surgery as the foundation. Now, how do we optimize these kind of centers is what I've been researching in my PhD. Let us all look at this picture. I won't let it on for too long for the more sensitive persons here, but this is what's important for us. Living or dying, do we have a limb or do we lose a limb? The main question is, when you go to a doctor, what are we gonna do with a limb when you have a surgery, accident, malignancy, anything in your arm? Are we gonna amputate it, or are we gonna try to salvage it, rescue the limb? And together with this, as you all know here also in the session, there comes a whole lot of different multifaceted structures, decisions, providers that we have to hold account for. When we look here, we see amputations. I will describe it for the people not seeing it here. We see amputations, and as we know, a loss of an amputation is something that makes us feel unwhole, incomplete, making it hard to see ourselves as a whole human with everyone around us having that part. But still, it's very functional, and we're very adaptive. So we have to make the decision sometimes, which is pretty radical, when to take a part from another place of the body and put it in a place where we can actually make better use of it. Let's say this amputated part of the arm that came in with an accident. So this is a loose arm, but it still has a thumb. If we have a thumb on the other side of the hand and arm that's missing, and we have a specialized team in between 24 hours with every mental health care, surgeon, social worker, providers that we need, we can actually do pretty cool surgery where we can take it from one side, bring it over to the other side, and have it eventually function over the years as a full hand. And this goes with a lot of other factors where we need a complete system, which we call multidisciplinary approach. As we all know, this is tailored towards the patient's needs, managing patient expectation, and having shared decision-making with and the other providers, but also with the patients. Now, I've talked enough, I think. Let's see how the other people are thinking. For you, Adriana, you have a tremendous amount of experience with different healthcare institutions. When you go there and you see an institution not doing too well with poor patient outcomes, what's the most significant system bottleneck that you could find there? I'll give you mine for now.
Thank you. So I think all of us struggle with communication in general, and I think that bottlenecks are not necessarily one process, the department, or unit, but it really comes to how everything comes together. When we look at the patient data, a lot of the complaints come from having a good experience somewhere, but it's not consistently followed throughout the health system. So top 3 complaints I see from patients are fragmented communication throughout the system, silos, departments working individually, and then the lack of understanding of what's actually going on in real-time data, real communication with them on what they need to do next. And so how do we fix it? We're all in healthcare here. And so 4 things I'll quickly share with you on how we fixed it, and I typically work in new organizations that implement patient experience. First is clear expectations, especially stemming from leadership. Right? I think we hear there's a Disney term coined the North Star. So what is the organization's North Star? Is it to follow the policy, or is it to serve the patient? And a lot of times when we lead by example, having leaders with, doing leadership rounding, something called elevator talk, simply engaging with our staff and patients in the elevator, asking how their day is. A lot of times us as leaders, as we're walking around, we find patients that are lost, right? So being able to kind of be the glue in certain areas where we might not have resources to as leaders is very important. Another thing is standardized processes. This can hurt us in some degree because sometimes we say the policy doesn't allow, but at the end of the day, a lot of us, especially here in the JCC, we want the JCI accreditation. We're all aiming to be magnet certified. How can we excel in this way? And so being able to have a health system to where everyone's doing the same thing because it's the policy to do it is really important. Another thing that really helps is digital tools. We talked about AI in the last panel. We implemented something called a happy or not on the front counters. And I think you've probably seen this in the bathrooms where if you're happy, you press a smiley face, or you're unhappy, you press a sad face. It's the small little things by having communication channels throughout the system that have really helped us and help empower the teams to take ownership when things go wrong. Because not everything goes right every day. I think there's more wrong to a day sometimes that we focus on than the positives. But this allowed us to be able to, when the patient will click it in the department, the lead gets a notification or a message on their cell phone, and they're able to come out and service recover right away. If we wait 1 month until we get the data in our executive committee meetings, that's not going to be good enough when it comes to being able to empower a workforce to know what's going on and how to fix it. A lot of us have huddles in the morning, and usually those huddles are what's the bed capacity, how many surgeries do we have today, how many patients do we have in our facility. And what we ended up doing, which I think is important for everybody, is share a patient story. Go on Google and find something positive that happened the day before, and then something that maybe didn't happen very smoothly, and work as a team. We heard co-creation a lot today. Work as a team to be able to fix together, because if we don't talk about these things are going to get buried, and we're never going to be able to fix them. And then last but not least, if you're able to do this and really hone in on the communication, I find that you create an environment where people are all empowered and the fear is not necessarily there anymore, especially when it comes to staff. And then we're all co-creating a better experience for everybody. Thank you.
Thank you. I couldn't make it more whole than this. Honestly, it goes from everything that I've today. No, you're good. I just have to keep it a little bit closer. So what you said is it's not only... Oh, okay. Thank you. So what you said is actually something that we see here. It's patient-centered care with a lot of different facets in an organized system, well coordinated and tailored to the patient's need, with proper use of digitization, the tools that we have, like before the instance of a phone, easy accessible, low threshold, instead of all those hard dashboards what people make with emojis and everything. We want to make it as easy as possible. And that is what has been proven also in my PhD as effective. That weekend broad, I've been asked to keep it a little bit shorter than we actually have, so I'll go through a lot of slides, maybe not too much into the weeds. If you have any questions about anything you see, please come and ask. I want to keep it as light as possible because I know everyone can also be more tired this first day. So what we want is what we see here. Systems can give patient satisfaction. One of my studies shows that 86% of satisfaction is possible when you have a coordinated system. Although someone has lost a limb, that is the amount of amputation adaptivity, as long as you have the right kind of resources allocated at the right place. So when we go further to Dr. Frida, so when we systematically try to protect the patient, there's always the care provider on the other side. But how do we actually have the care provider provide the best possible care, maximize efficacy of the care, while at the same time also tailoring it as much to the patient's need? What do you think from your broad expertise? Of course. So very easy. How to systematically protect provider capacity while maximizing cost-effective care for the patient.
It works. Okay, so when we talk about the capacity, it's not, the cost or something, it's not by reducing staff. It's within the system, within the well-being of the staff, the providers. So when we talk about removing duplication of work, repetitive work, okay, and then we try to minimize that, so freeing time, more time for the care provider to do the meaningful care with the patient. That will increase the outcomes, we don't need to lower the cost, but the outcome will come more and more. So focusing on the processes, focusing on the workflow, redesigning it from the beginning to free that time for the people. Also embedding the emotional resilience for the staff. It's not a soft skill. It's impacting very excellent or beautiful on the staff, because it will reduce the turnover, the burnout, and then beautiful outcomes, because there's no cost over there. You're just investing on their well-being, because they are burned so easily. So you need to work on that one. Lastly, empowering the patient as partners. So engaging partners, keeping them informed all the time, will make them use more the service. Okay, and then they will be more engaged, and that also will make the outcomes up and up and up again. So they will not complain, they will be more engaged with us, and then, so it's not add capacity, it's unlock the capacity within. Okay, so the well-being, emotional resilience, and partnership of the patients.
So, if I understand it correctly, it's mostly about having the most effective care, where you don't focus on everything, but you try to focus on the things that actually matter, not only for the patient, but also for the provider. And that, of course, is a beautiful bridge. How can we do that? And that is something that we've also done and researched a lot. So my research is mostly about saving a limb, right? Saving the arm or leg. This is a very old technique where we can use different parts called the free flap from different parts of the body that is actually usable to put in a different place. This goes with a lot of inefficiency. What we see is that every day, every hospital day, that a patient is in the hospital costs about $5,000. If there's just one element that's not efficient or effective, it will have a tremendous effect not only on the patient with complications, having all the different financial burdens of the patient, but also for the whole healthcare system, hospital, and eventually also the people paying the taxes over it. And this is exactly where we're standing now, I think, in not only limb salvage, but also in the world, finding the right factors that we can use to make more effective, efficient, and tailor those to the patient's need. Now, if we're looking at all this, a lot of it is planning and organization, which is blue in the upper part. And then what we see here, hidden by our beautiful panelists, is the patient factors. So where is he coming from? What kind of nutritional status? What kind of other diseases, comorbidity? And then when he gets to the hospital, around the surgery, what kind of factors do we do? Surgical, but also the other needs. And then eventually, we only try to do our best, but they can also get impacted by hospital stays. So there's also the negative kind of influence with hospital-acquired infections, etc. So overall, a lot of factors, and trying to find the ones to make it as effective as possible, we should use the patient as the guide to get us there. So talking about the patients, we have patients living all over abroad. This is from a study where we try to associate also the destination from where the patient gets discharged to after they leave, something I'm getting right to you back there. When we talk about these factors, we see coordination, again, between specialists is the most important thing for patients to leave the hospital. But what about patients actually when they get home? So for Adarsha, how does continuous home monitoring further reduce unnecessary readmissions while maintaining the safety? Because when we let them leave, we don't want them back.
Yeah, hi.
Did you hear the question, or shall I repeat it?
Yeah, I can repeat once more.
Of course. So when a patient leaves the hospital, we did surgery, everything's well, they're standing, we want them out as soon as possible because we have a lot of others coming in. That's the strain, the work strain, of which Neda was talking about, of us as doctors. We don't want them to come back if they're living that far away. So how does continuous home monitoring, which you're experienced in, further reduce the unnecessary readmissions while maintaining the safety for them? Because we also don't want them, to be impacted at home. So where is this balance?
Sure. So continuous home monitoring hinges on the concept of early intervention or proactive intervention fueled by data. If you're rightly implementing it, we can create early warning systems. For example, of a heart failure patient, I can check the leading indicators such as the weight, the pulmonary sounds, oxygen saturation monitors, and I can see whether the patient is getting deteriorated or is getting better. By using systems like that, we can know what is, yeah, that is the first point. Creating, okay. And the second one, we can reduce patient anxiety. Often patients come back to hospital because of anxiety, right? If we are able to put devices and sensors onto the patient, they will be also assured that someone is monitoring them. And that can coming back again, right? So that is the second point about reducing patient anxiety. So if you are able to implement this correctly, we can change from the current episodic reactive system to more proactive and preventive care system. So we'll need more of these devices, sensors. Mainly, I will talk about the non-communicable diseases. If you're having this, rather than patient going out without any data, we'll be able to monitor and make sure they don't end up in a ER again. So that's what I can say.
Okay. Beautiful answered. When we use those systems and we actually get back to the hospital, you will still need the people in the hospital to check those, right? Is there anything that makes it easier? As we talked with Nada, we don't want to work strain it more. Can everyone look at those, or?
So I think there can be a system of nurses.
Yeah.
They can triage based on the data as well as the history and context of the patient. And I think they will be the first person before it goes to the.
Thank you. And that is exactly what we see here again on the screen. It's the effective care put at the right place with the right resources instead of incarnating the impact for the doctor. There's someone else that can do it and become a filter so that the doctor can be more effective with more complex care. And this is exactly why the workflow, the coordination is so important. Once you have this in set, you can become a superhero in the hospital doing superhero stuff like replanting fingers, amputations to different places, all in between 24 hours, which we have shown in our latest paper of the emergency-free flaps. So it's a reconstruction that and the orthopedic surgeon and the plastic surgeon have to be together in 24 hours in the operating room since the accident. Only then you can get a thumb like I just showed you, transferred to the other place. If the coordination, because they have to monitor another patient that came home, like after going home, came back to the hospital, it's exactly what they won't be able to do, and someone eventually gets impacted by not having a thumb for the rest of his life because the doctor was checking the monitor of another patient. And that is where we want to go with the future of the hospitals, making more effective care, better outcomes, and everything that is necessary with, of course, also use of digitization. So, Dr. Filipovic, how can we apply the oncology of the optimized ecosystem? Is Dr. Filipovic not here? Didn't come? Moving on. The financial burden part is something that I will have to skip over. The financial burden part is how much it costs for the patient to actually get the care, even though that they are very socially protected, so they have high insurance and at the same time also pay deductibilities, so meaning they have to pay some out-of-pocket expense. We see a tremendous amount of impact psychosocially throughout time on reduced function, quality of life, and eventually also return to work. We can find different factors, which I will skip for now. I want to go over to Dr. Sharma, where when we're talking about all of this, patient is centered, right? Now all these hospitals are talking about money, productivity centered. How do we rebalance the outcomes, what we're looking at, from volume revenue to more patient-centered metrics?
Actually, we have been, like from the beginning, we have been.
I think. Yeah. Can you just audible?
I think we have been discussing this. This is the center point of all our discussion. We have to, future of the design of the hospital, the future hospital, has to be patient friendly. But when we say the design has to be patient friendly, that. So, will you? Yeah. So we say that the future hospital, the designing of how do we design the future hospital? When we say that the future hospital has to be patient friendly, the better results for the patient. It cannot be possible if it doesn't translate into the better revenue for the hospitals. It is not possible. So the end of the matter remains, when you yourself has shown in your research also, when we are talking about the older hospitals, when I come from India, most of the hospitals most of the older hospitals, the big medical colleges, they were built in 60s, 70s or 80s. So they have the old design. You have the different department and different settings. If the patient comes, how the flow is, he will go to the OPD or he will go to the emergency. From emergency, he has to go to the radiology. And then from radiology, he has go to the lab. So all those things, the patient goes there are a lot of transfers involved in this process. So if now we get a chance to redesign a hospital, it has to be patient friendly. As you rightly said, if there is an infection, the patient has been if there is a transplant which has been taken place, and the patient is going through a lot of transfers, what will happen? There will be a lot of hospital-acquired infections. The atmosphere will keep on changing. So that is what we say, that we need to reduce the transfers when we design the future hospital. We need to create smarter hospitals. We need to create hospitals who work on the better patient outcomes through the objective is to reduce the healing time. And how do we do that? We do that by reducing their hospital stays. And how do we do that? We need to do that by creating an efficient system. And then how do we do that? So that is the chain. And this needs to be done, as all of my co-panelists rightly said, that you need to be patient friendly. And as you rightly said, that you need to take care of their budgets also. And then the question is, the system needs to be more efficient. You have already explained it well, that one of our co-panelists who was not there, you have asked about how does the emotional and the patient psychology, how does it, if the patient is more anxious, if he's having more stress on his head, the recovery will be slow. But if his anxiety levels are low, and if he's having that belief, yes, that I'm in good hands, and I'm well taken care of, he will get to the recovery stage faster. So the future hospital need not to be bigger. The first answer to your question is, let us don't spend that much, for which we just need to look at the revenue rather than the results. So we need to have smarter hospital, smaller hospitals which are with their focus on the patient results. You need to have hospitals where you can save on a lot of lighting. You have to have the optimize natural lighting, and patient need to feel like that they are working more at home and less at hospitals. So you need to have those kind of biophilic, I will say, designs for the hospitals, which will save a lot of revenue to the hospital, and which will result in faster patient recovery, and the same bed will treat more patients. So I will say, you should not measure the success of a hospital and how much revenue it is giving per bed, but how much patients you are treating per bed. So I will say, it is the success of the future hospital has to come from not revenue per bed. It is the number of lives saved per square feet.
That's beautiful.
So, and the revenue will take care of itself. You just keep on taking care of the patients. I'm sure, I have more than 25 years of experience. I am working with a medical device company. We are from a cardiology, I come from a cardiology background. So if you treat a patient from a heart attack or say for heart failure, the more number of days patient stays in a hospital, these patients, so the chances are that his hospital, he will acquire some kind of infection from the hospital, and then the stays will increase and all those things. So the better is that you just treat him in a way that he just get off the hospital in a faster way, and your revenue is saved. You treat more patients.
That's beautiful. I really like what you said. It's not about going bigger. It's about actually maybe doing more with less, right?
Yeah,
So
yeah.
being more cost effective with what you have, the resources, to actually also tailor it to the needs. So for you, Dr. Gabelli, when we could use all the digitization with the AI revolution and everything around us now, how do you see it going sideways when we don't have these systems already, and then we already try to apply the AI on it? What happens if the infrastructure and system is not good?
Well, I observe what happens in our hospitals nowadays. We know that they are not particularly patient-friendly. They are horrible places to try to sleep and rest and recover, and they are very challenging environments for clinicians very often. When we try to implement AI without upgrading our systems, our old hospitals, what can happen is disruption and inefficiency. For example, we see that nowadays where we struggle to find computers that work very quickly. And with our own devices, we would change them yearly or every couple of years when they slow down. In hospitals, especially publicly funded hospitals where I happen to work for the last 25 years, we often are disrupted by waiting to log in into a system and another system, made worse recently by two-factor authentication for every single step of the way. Other things that sometimes we don't think about. If you ask at the IT department about the hospital of the future, they will give you very precise figures about, for example, the power of your broadband, your network, your Wi-Fi. Will they think about what impacts the clinical team day by day? I'll give an example. What I'm experiencing right now in my hospital, we have a lot of computers on wheels and very few sockets in the corridors where to charge them. And I work in a hospital that has been recently developed by architects that are expert in hospital design. So what I'm trying to say is not taking into account the lived experience of the clinical teams can really have a negative impact in the future of how we use the technology.
So again, the collaboration between the architects, the people that are specialized in that part, doing it effectively, all together with the people that are experienced it with the actual care delivery to the patient. That is what we need, better collaboration. So eventually we looked into different institutions worldwide, all these limb salvage centers who are highly specialized in doing exactly this, finding the right person, specialty, putting them together in a center so that everyone has these smaller and easier connections towards each other. We looked at their organizations, where and which factors we can actually see with different team members, and what we see is a huge amount of heterogeneity. For the people not knowing that, it means that everyone is pretty cowboying their own thing, and that no one is actually using a standard template into doing this. And we're talking about one of the most complex kind of surgeries there is, and people are still cowboying, let alone what happens when people do this for more easy, lower threshold kind of care. So what we need, I'm sorry for the overwhelming slides, is structure, coordination, organization, so that we can collaborate in a good sense. And that is where you make frameworks after analyzing a specific structure to actually tailor it. Now, with our eyes on the time, for you, Adriana, what is your experience in the system application and the differences with the culture bridging in between those systems? Can you apply it in any culture in the same way? How does that difference look?
Thank you. So I think we all know healthcare is leading to personalization and not one size fits all. So I have the pleasure of working with cultures like Iraq, Libya, and Doha, and all of them have a different understanding of what good care is. Not only that, but the systems are different. So a lot of our processes in international market is manual, while Doha has a lot of technology, but I think it's really important to listen to understand what good care and practice is for them. And then we talked about co-creation and collaboration. When I go to Iraq next month, I'm spending a little time with the leadership and most of my time with the frontliners, because the frontliners really know the day-to-day struggles and what the culture needs to enhance. And in addition to that, we all came in healthcare for one reason, to make a difference. Money's okay, everything else is an additional benefit, but we're human. So I think it's coming back to treating each other like that and building the trust. Thank you.
So building that all together, we of course have to keep in mind what the frontliners want, which is something that you can also ask them. So we can use surveys as we see and ask the providers, hey, what is it that you deem essential and what is it what you deem or have currently? Based on that, we can actually fulfill those realizations towards them and have structured systems towards the needs of the care providers so that they can also effectively translate that to effective care for the patient, which you can see here again as a process framework of the context, structure, the process of someone getting in, and eventually better outcomes, as we said before. So if we ask the frontliners, what are the current barriers? Why is not everyone doing this? And then what we see out of one of our researches is that lack of standardization, because everyone's cowboying, we can't make our own rules. Insufficient institutional support is one that's also over the barrier, and then the lack of eventually the standardization of institutionalized frameworks. If someone higher up is telling me I need to make more productivity, I can do that, I want to do that, but also tell me how if someone else is telling me what to do now, as surgery, for example. So this combined, everyone needs to collaborate together. And back to you, Dr. Gabelli, what are the barriers for the people that we actually have to ask for the money when we want to change something? Have you experienced some kind of techniques that you can also help our listeners with?
Well, I was referencing to inefficiencies, and I think that is something that is both very difficult to quantify, but crucial when it comes to asking for funding for investment. For example, I give an example of slow logging in, slow functioning equipment. If you time that in itself, time is a measurement of inefficiency, but you can also factor in the outcome on the efficiency of the people, how that impacts on their stress levels, how they become grumpy, litigious, how that transfers on to patient interactions and complaints and litigation. So if we limit ourselves in just taking into account the initial investment, the cost, without seeing all the additional advantage of implementing new technology, investing in infrastructure, we might only see a part of the bigger picture.
When we use that, I'm going to go over this, and we, as we heard, do that in an effective manner, we can actually get pretty good results. These are the results for the limb salvage patients, so most complex care. We see it holistically approached, that there's still a lot of heterogeneity between the patients, why they're coming in. That is also for every institution, like we said, less resourceful if we don't have everything we need, we don't have the money or funds, but we still want the same outcome, and that is long-term good outcomes for patients. Well, this is very easy to say, I have to say, from a Western perspective, where everything's there and we're still complaining, don't get me wrong, but we're still complaining. But if we want that, we should also look for the future. And it's perfectly hidden there, but for the future, we also want to apply the right digital tools. Now, talking about AI in the panel here before, we want to go and see how the digitization actually is implemented currently and where we should be going to in the future. So, Nada, for you, how do you think we can best leverage digitization to optimize the outcomes, but at the same time, make it less strained for the people providing the care?
Okay, we need to agree first that digitalization or AI is not coming to replace us at all. So it's coming to help us, to support us, to make things easy and friendly in work. So saying that, it means making work, as I said before earlier, less. Okay, using the tools of digitalization, minimizing, freeing more time for us to take care, to do the emotional support we need for the patient. So digitalization is there, and it has to be there, and it's coming. But how to make it efficient and easy for us as a staff or a care provider to use it and to work it out with the patient, and building the trust with the patient to trust that AI, to use it. Okay, so we need to talk to them, we need to tell them, we need to teach them, okay, because it's coming. And how can you tell a patient to trust an AI operating for him? He cannot accept it now, but future-wise it's coming. So we need to start from now, explaining things, how things are going to be, and make it easy for them so they can accept it day by day. Also, the tools, it has to be friendly users for patients and for care providers. So when it's more complicated, we're not going to learn. We don't want to. We will just resistance. So make it more easy, like the smartphones. When the first time it appears in our life, it was like, no, I still remember my father says, don't. No, I need my phone. Don't give me the phone with a camera or so. No, I don't want it. But now he's using one. So it's coming, but one by one. So we need to accept it first and teach others.
And engage.
Yeah, sure.
Engage
This is the teaching. Yeah.
teaching era. And that is something that we want to fully entrust. So there's a lot of research going on back in Boston. We see that using imaging techniques, AI does way better jobs at pattern recognition. And then to bridge over to where we want to get, what if we can use for every patient and put in the factors to actually see where we eventually want to go, and to make the machine tell us if we should provide that specific type of care, surgery, amputation, emotional resilience, psychosocial support if they don't have financial restraints. All of these examples is where we're going to, but we need to let the patient also engage to trust it just like we are learning to do it. So a lot of accuracy kind of results, but the future, just like Dr. Fida said, is coming, and we should learn to embrace it. Now, with an eye on the time, we should be closing up, where if we're talking about everything, Dr. Darsha, we didn't talk too much about the medical devices yet. So we have AI on our phone, and then we also need like all these robots that are being built and everything, but we also need hardware to make something well. How is that for you? How do you think that integrates in the future?
Yeah, I am Adarsh. So as a researcher, we focus on improving the accuracy or F-score, right? And clinicians, it doesn't help because clinician cares for explainability. Currently, there is this problem of black box, right? There is input and there is output. No one knows how the input is translated into output. And the problem of accountability. If something goes wrong, is it the algorithm or the doctor, right? So until the researcher solves for these problems, this gap is going to widen, and I think more work needs to be there to reduce it.
I think I would like to just add a little bit to what Dr. Fida said and what my friend is saying. Like, see, end of the day, all the technologies will fail if we don't train the stakeholders, the doctors. If the patient will only get benefited by technology, if if we are like using that technology, and the technology has to be used, like say AI and all these devices, they have to be used by the doctors and nurses. And most of this technology, because the compliance is poor, as she has rightly said, that nobody wants to use a new technology. So that fear of getting into the complexity of the things has to be removed. So the training and the compliance go hand in hand. So we need to create that model that more people, doctors, nurses, the stakeholders who are involved in the implementation, they are first trained, and they are actually taught, they are aware that what benefit it is translating to the patients. And I tell you, most of the benefits which we are talking, which we are translating to the patients, most of these benefits will actually go to your bank. We need to make the management understand the question which you are asking, that how are you going to, the difficulty which you are facing, that for the infrastructure and everything, you need to go and tell them that we are going to get more revenue by treating more patients, better patients. You know, one thing we are forgetting in all this is that everybody struggle to get more patients. So we want to treat more patients with the same infrastructure, will get more revenue. But from where the more patient will come? Every happy patient will tell five patients that yes, this is the place you need to go. This is the surgeon you need to go. And if you are coming out happily, see, we are actually, when we treat our, like, who are our customers? Patients. They are never happy. They are always in pain. They are in frustration. So we get people who are absolutely in the worst state of their mind. And our job is complex. We need to make them happy once they go. And even if we don't want them to come back again, but yes, what we want them to send more people whom we can serve. And that is from where our revenue will come. So probably hospital need to be a place where people have to go. They don't come back again, but they will send more patients because, yes, you are doing a nice job.
Yeah, exactly.
And that is how AI will help. You reduce the time, reporting time, say if your reporting time is, if you're doing a manual reporting, in one of our earlier session I was attending to, somebody like one of my panelists, he was saying that reporting time in US hospital was, they used to report in 3 to 5 days. Yes. And then after the inclusion of AI, they are reporting in 3 to 5 minutes. So you can understand, if a patient is posted for a surgery, say after a week, because the report is going to come in 3 days, and you can just operate him on very next day or very next week. So how much revenue the hospital might have saved because of this? So that is what I believe actually.
Me too.
Yeah.
That is exactly.
So we have a conclusion on this.
Yes,
yeah.
that is the big conclusion,
Yeah.
I think. And
Yeah.
I think with the right allocation, again, of the resources, not only in the system, it has a huge impact, reducing a lot of workflows. But this has been proven, evidence-based is what we need. We need
Yeah.
to learn to trust it. We need to learn where to allocate the right persons, resources to provide the highest kind of effective care. And this formula is actually applicable in a lot of things. Not only healthcare, where we tend to be a little bit more conservative than a lot of other places, but it will take time. We need to trust. And we can also have the architectures, as said earlier by Dr. Garbelli, where I have been also trying to bridge this more to whoever needs this. If there is anything you want to talk about, think about what kind of workflow coordination you need, my details are here. And with that, I actually want to thank you all with a beautiful amount of multifaceted kind of expertises. I think we provided a good picture. If anyone has any questions, please let us know. Thank you.